Thanks, Mr. Chairman, for the nice introduction. So today I will talk about CAR T-cell in my institution, which is National Guard Hospital, Jeddah. So as we know that actually CAR T-cell was approved as initially third line. We have three products like Axi-cell, T-cell, and Lysocell. Then two of the products, Axi-cell and Lysocell, were approved as a second lines. In my institution, we have only Axi-cells. Yes, I think National Guard, Riyadh, they have Axi-cell and T-cell, even King Faisal Special Hospital. We don't have Lysocell in Saudi Arabia. As we know, like CAR T-cell makes huge difference in management of relapse refractory diffuse large B-cell lymphoma because usually these types of patients, they are chemo resistant, even if they achieve partial remission and then underwent autologous stem cell transplant. Majority of them actually will progress after 2 to 3 months post-transplant. That's why CAR T-cell makes a huge difference. So actually the CAR T-cell program in my institution was started in May 2023, so still less than 2 years. So until now we have actually 27 patients had infused with CAR T-cell, and like I mentioned, we have Axi-cell products. So what are the disease features for these types of patients? So when you look actually at these 27 patients, actually 24 patients had diffuse large B-cell lymphoma, and 3 of them are follicular lymphoma. And we know that early versus actually early and primary refractory diffuse large B-cell lymphoma, they do worse compared to late relapse. So when you analyze the 24 patients, actually, you can see around 54%, which are the 13 patients, actually they are primary refractory. 6 patients, they are early relapse, and 5 patients are late relapse. So as I mentioned, CAR T-cell approved as second line and third line. So what these types of patients, so how many CAR T-cell at the second line, how many CAR T-cell beyond the second line? So as you can see here, actually 19 patients, actually they had CAR T-cell as a second line. 8 patients CAR T-cell beyond the second line. It depends either follicular lymphoma or third line in case of diffuse large B-cell lymphoma. So these are the 27 patients that show the number of prior lines of therapy. So just to show that this patient had 4 lines of therapy, this follicular lymphoma patients, the majority they had only 1 line of therapy. Some of them have 2 lines of therapy. But as you can see, most of them, they have actually 1 line of therapy before the CAR T-cell. So we know once we collected the lymphocyte, and because the manufacturing usually takes like 3 to 4 weeks, and these types of patients are actually, they can, primary refractory relapse, they cannot wait long time without any therapy. That's why we give what we call bridging therapy. The aim just to keep the patient stable. So the aim of bridging therapy not to put the patient in CR, just to keep him stable, fit until the product is ready. So in my institution, actually, we are using BOLA-based regimen bridging. So you can see here, actually, we used BOLA-based regimen in around 21 patients. It depends, BOLA-R or BOLA-R-GMOX. 4 patients require radiation as a bridging therapy. 2 patients did not require any bridging therapy. At that time, most likely disease burden was very low. So, and this actually the PET-CT after the bridging and before the infusion of CAR T-cell. As you can see here, 13 patients, the majority, they have like DEVOL-5 before the infusion of CAR T-cell. 6 patients, they are partial remission, and 8 patients are complete metabolic response. So what are the results? So actually so usually once we infuse the CAR T-cell, we assist the patient by doing BIT day 30. Then it depends on the response. If the patient achieves complete metabolic response, we'll do BIT day 90. But if the patient achieves partial remission at day 30, we need to do BIT at day 60. So BIT day 30, actually, here you can see we have 25 patients because there is 2 patients still not yet reached day 30. So 16 patients, actually, they achieve complete metabolic response. 5 patients, they are in partial remission, and 4 patients, unfortunately, they have progression disease. So what about these 5 patients? As mentioned, if they are like having partial remission BIT day 30, we need to do BIT day 60. So BIT day 60 was done. 2 of them, actually, 2 from 5 patients actually were converted to complete metabolic response. The other 2 continue to be in partial remission. Third, unfortunately, the 5th patient, his disease progressed. What about the 16 patients who had achieved complete metabolic response at day 30? Actually, 15 from 16 patients continue to be in CMR. Only 1 progressed at that time. So until now, actually, I have like the total 27 patients. 24 are still alive. 3 actually they passed away. Main reason, disease progression. And this is the same. So this is just the percentage. And what about, so we talk about the efficacy. So what about the toxicity? And toxicity mainly we're talking about CRS and ICANS. So we know that actually in like ZUMA 1, they used, I put in cohort 6, sometimes you can use steroid prophylaxis to decrease the incidence of CRS and ICANS. So here actually we used steroid prophylaxis in around 21 patients. 6 patients did not require any steroid prophylaxis. The reason we're using steroid, because at the time when we started the CAR T cells, so we are little worried about the toxicity, and especially if the patient has like active disease. But with time, starting actually gradually decrease using the steroid, even if the patient has active disease, because the team already start to have some experience with how to manage toxicity. So CRS, so all the patients, they develop actually CRS. We define that at least by developing fever. Unfortunately, we don't have a way to differentiate. Is it like febrile neutropenia, just febrile neutropenia, or this cytokine release syndrome? That's why we assume any patient who had fever after infusion, this is CRS. So all of them, they have CRS, but what about the grading of CRS? If you look here, actually 21 patients, they have grade 1 CRS, and 5 patients have grade 2. We haven't seen grade 3 or 4 CRS, so just grade 1 and 2. The majority are grade 1. And this is actually reflect number of tocilizumab doses given to the patient at the time when they develop CRS. Usually, our protocol actually, if the patient spike fever, will wait 24 hours, and actually we start antibiotics and we manage as febrile neutropenia, then we'll wait 24 hours. If the fever not subside, we'll start to introduce tocilizumab. You can see here actually, this is actually the number of tocilizumab doses, 0, 1, 2, 3, and this is the number of patients. So 2 patients did not require any TUSI, 3 patients required dose 1, 2 doses, 3 doses, and actually majority, like 15 patients, they require 4 doses of tocilizumab. What about using steroid as a treatment of CRS? You can see here 16 patients actually did not require any steroid to treat CRS. They managed by the tocilizumab. 11 patients required steroid to treat CRS. What about ICANS? So in the 27 patients, actually 23, they did not have any ICANS, only 4 patients. And what are the grade of ICANS in these patients? So 2 of them, they have a grade 2. There is no grade 1. There is no grade 2. And 2 of them, they have grade 3. And we haven't seen any patient with grade 4. ICU admission, actually, we have those who develop ICANS as a grade 3. Actually, they needed ICU admission, but actually, they stayed in the ICU only for 48 hours. After that, they were discharged from the ICU. The rest, they did not require any ICU admission. What about GCSF? We know neutropenia common with the CAR T cell. So in our institution, we'll wait 2 weeks. If the patient neutrophil not recover, we introduce the GCSF. So as you can see here, actually 19 patients actually they required GCSF. 7 patients did not require any GCSF support. So from the 27 patients, actually we haven't seen any death after the lymphodepletion in the first 30 days. Only 1 patient actually, after 1 year, progressed disease, and his disease from those who achieved CMR after 1 year, only 1 patient had progressive disease. So conclusion, CAR T-cell showed excellent result in relapsed refractory non-Hodgkin lymphoma, acceptable toxicity profile. Of course, the limitation is short follow-up and small number of patients. It's retrospective. Of course, before my conclusion, actually, I want to thank all the team, actually, the physician, nurses, pharmacists, BMT coordinator, stem cell lab, and pheresis unit, neuro and ICU team for their great support. And thank you.